not work very well. The summary of the emerging strategies against TKIs, third generation TKIs osimertinib. And these are for the MET, selected by the MET amplification. So the tepotinib, savolitinib, the MET TKIs, and you select the patients by the higher MET amplification, higher by the any molecular mechanisms. So this one is again amivantamab resertinib, and this is a HER3 ADC patritumab deruxtecan, and this is TROP2 ADC, and also I mentioned nestumab plus osimertinib. And a different approach is the use of the immunotherapy. So as you may remember that the IMPOWER 150 study, which combined atezolizumab with chemotherapy plus bevacizumab, showed some activity for even for the EGFR ALK plus patients, but that was exploratory analysis. So Dr. Liu et al. Decided to test the hypothesis that chemo plus IO plus anti-angiogenesis drug may improve the efficacy of this combination for the EGFR-mutated lung cancer. So this is the 3-arm trials. They use sintilimab, PD-1 antibody. IBI is biosimilar of the anti-VEGF antibody, bevacizumab. And these are 3 antibodies. So this one, R1 is anti-PD-1, anti-VEGF plus chemo. And this one's anti-PD-1 plus chemo. And this is control, that's just chemo. So last year, about 1 year ago, he presented this data and showing that PD-1 VEGF, so that Arm 1 versus Arm 3 was superior. And this year in the ESMO meeting, they presented data comparing the anti-PD-1 plus chemo versus chemo, and showing that not slight, but significant improvement of the PFS. And next year, on Arm 2. So in that case, we will know the effect of adding the anti-VEGF in this situation. The response rate appears to be incrementally better if you add more drugs. So this is another interesting approach. We don't know how to use the IO drug for the EGFR-mutated tumors. In general, EGFR tumor is resistant to IO therapy, but this strategy may change our paradigm. Okay, so the exon 20 insertion mutations is another recently very hot place for the drug therapy of the lung cancer. Exon 20 insertion mutations in general very resistant to the currently available TKI, so there are many efforts of being made. Small molecules, many small molecules. In the United States, mobocertinib and also bispecific antibody amivantamab is also already approved. And if you look at the structure of these small molecules, they all have the acrylamide, which is important to make a covalent bond with C797, cysteine C797, and also the pyrimidine base. I only have the six minutes, so I have to be quick. So this is the CN081, originally developed by Taiwan, Japan, and showed relatively nice. But compared to the other TKIs, it's relatively bad. And the nestumab osimertinib is the same study for this cohort of the exon 20 insertion. And this is a comparison. So in most cases, the rash is relatively frequent, and the response rate-wise, the amivantamab 40%, CRNL 38%, and another TKI, mobocertinib 38%. So compared to the other targeted therapy of lung cancer, the efficacy is not so great, but But there is a great unmet need in this. Then MET. So the MET target is MET-targeted TKI, selective TKI, and antibodies, monospecific, bispecific, and the ADCs are present. And this is the summary of the activity of the crizotinib, capmatinib, tepotinib, savolitinib. And then Glory studies a new MET TKIs, and a similar activity was presented. Then Chrysalis amivantamab is EGFR MET bispecific, so it is also active in the MET exon 14 skipping. And this is a summary, but the left part is I already mentioned. This is the EGFR resistance MET amplification for the EGFR TKI after the EGFR TKI treatment. So only the MET amplified lung cancer is also can be the target of the MET TKIs. But again, depending on how you select the patient is the degree of the MET amplification. And then ROS1. ROS1, although the incidence of the ROS1 fusion is not so great, but there are many drugs. And in Japan, the crizotinib and the entrectinib is already approved. And if you look at the resistance mechanism, the gatekeeper mutation, which is the bottom of the ATP pocket, and the solvent front is the entrance of the mutation there is in general refractory to the pre-existing ROS1 TKIs. But the new one, like repotrectinib, or this is a first-line study. So the new ROS1 inhibitors, this is a first-line study, so the 78% is very impressive. And this is repotrectinib, and even naive setting, it's about 80%, but even with the pre-treated 40%, and G2032R is solvent front mutations, it's like 60%. So compared to the crizotinib or entrectinib, it appears that these are active for the solvent front mutations. And this is NVR 520. This is very selective ROS1 inhibitor that doesn't have the TRK inhibition. TRK inhibition may cause some cognitive disturbance. So that without lacking the TRK inhibition is very good. And G1232R is mutations, 78 responses, like 80%. So it looks like very active for this time. Finally, I'd like to mention about HER2. HER2 mutations about 1 to 2% of the adenocarcinoma of the lung. And there have been a lot of the clinical trials, and these are the pan-RB, so that including afatinib, neratinib, pirotinib, dacomitinib, and selective one include the poziotinib, and trastuzumab is a HER2 antibody, and ADC, trastuzumab emtansine, trastuzumab deruxtecan. And the response rate-wise, it's not so bad, 50, 40 something. But if you look at the PFS, it's relatively short, 5 months. But for the TDXD, trastuzumab deruxtecan, it's a response 55% and PFS 8.2 months. So it looks like the TDXD is the most efficient drug for this randomized phase 2 trial, because Destiny Lung 1 precedent trial showed that the efficacy is very nice, but ILD was reported on 26%, and G5 its treatment rate was reported in 2.2 months. So in this trial, they tested the lower dose of the TDXD, 6.4 versus 5.4. And the efficacy was no big difference. So the 5.4, 53.8, and numerically it's better than the 6.4. And in terms of the toxicity, it's very strange to note. In general, any grade toxicity was lower in the 5.4 milligram arm, but for the grade 4 or 5 were not reported in either of these arms. So probably, I don't know the patient background or patient selection may be different, but it looks like that this drug can be used without any serious toxicity, even with the 5.4 milligram kg. So this is summary. So I only have 25 seconds. So that I summarize the key data on these 6 meetings, and especially this year, we had many presentations about KRAS G12C. Instead, we don't have the many big advances in the ARC-RET or NTRK. And new agents are active being also actively sought, but it is getting more and more, so it's very difficult to catch up, but we like to do our best, and it's a problem that targeted therapy in general cannot cure the patient, just prolong the PFS. So in the future, I'd like to see the dream that targeted therapy or other combination therapy will eventually cure the patient with this kind of the driver gene mutation. And thank you very much for your kind attention.
Thank you, Professor Mitsudomi. I would like to now invite Dr. Nguyen Thanh Khoi for his presentation.
Good morning, everyone. I'm Dr. Nguyen Thanh Khoi, medical oncologist from Ho Chi Minh City Cancer Center, Vietnam. Today, I would like to present with you the impact of COVID-19 on lung cancer. First, I want to inform you a very important information that this morning I tested for myself COVID-19 and the result negative. You know that COVID-19 emerged in China on November 2019 and quickly became a pandemic on January 2020. I think there is a mistake here, not March 2020, but January 2020, we announced that COVID-19 was a pandemic. And because of its danger, many areas in the world were locked down or quarantined. And because of rapidly increase the number of patients with COVID-19, many healthcare systems were in the state of overload. All these things impact not only lung cancer patients with COVID-19, but also lung cancer patients without COVID-19. For lung cancer patients without COVID-19, we have to consider between the benefits of cancer treatment and the risk of COVID-19 transmission if they come to hospital. And for lung cancer patients with COVID-19, we know well that COVID-19 and lung cancer had negative impact to each other. So we had to balance between cancer treatment and COVID-19 treatment. It's very hard. So that we changed practice very much. So that I think due to change practice, we make poor prognosis for the patient, lung cancer patient with COVID-19. Fortunately, vaccination changed situation. So we can divide pandemic COVID-19 into 3 periods. Before vaccination, January 2021, we were in darkness. Several months after vaccination, January 2021, we were finding the light. And after boost vaccination, April 2021, as you know, we gradually recover from a severe outbreak. That's the reason why we are now together. And I think that we need to look back to what happened in the darkness for many lessons for the future. Fortunately, after 1 year and 2 years, we have many research to know the relation between COVID-19 and cancer. so that I have data to discuss with you. Firstly, the impact of COVID-19 on surgery. After that, the impact of COVID-19 on radiation. And finally, the impact of COVID-19 on systemic therapy. Firstly, the impact of COVID-19 on surgery. For the patient, lung cancer patients without COVID-19 had a longer time of waiting for surgery. Data show that there is no compromise on short-term outcome. Short-term outcome means the surgical margin, 30-day post-operative mortality, and new detection of metastatic disease is not different. But how about long-term outcomes, that overall survival or progressive-free survival? I think is it too early to know the result? But we can estimate that we will have a poor result, a bad result, because NCCN database show that if a patient a lung cancer patient had a waiting time over 8 weeks from diagnosis to treatment, resulting in reduced survival of 5 years from 54% to 48%. And the big question here is for the patient, for lung cancer patient with COVID-19, should we do surgery as soon as possible or delay until recover? Data demonstrated that peri-operative SARS-CoV infection increased post-operative mortality. For example, the odds ratio 4.1 if surgery within 2 weeks, and 3.6 if the surgery within 4 to 6 weeks, and equals baseline if over 7 weeks. And you know that if you do a surgery for the patient with ongoing system, we have higher risk of mortality of 6%, then recover 2.4%, and no symptom 1.3%. And there is an elevated risk for the patient with lung cancer with COVID-19, with pneumonia, respiratory failure, and sepsis compared with the pre-COVID baseline. Remember that after 8 weeks, risk return to baseline. So I think that if the patient with a lung cancer patient with COVID-19, we have to wait for at least 7 weeks to perform operation. This is surgery triaging depending on COVID trending and hospital results. You can see here if there are few COVID-19 patients, intact hospital results, COVID-19 trajectory not in rapid escalation, overall statement is surgery risk are 2 patients in whom survival will be compromised with delay of 3 months. So that you can see here many patient surgery as soon as possible, and less patient surgery postponed by 3 months. And if in situation if that there are many COVID-19 patients, hospital resource limited, and COVID-19 trajectory in rapid escalation, you see that surgery restricted only to the patient in whom survival will be compromised in delay for a few days. So that we can see here that a lot of patients postpone surgery for 3 months, and less patient surgery as soon as possible. That the surgery. This is the changing practice for radiotherapy. They say that such means safety, avoidance, rescheduling, and shortening. Safe means to do everything to limit or to interfere the transmission of COVID-19, such as telemedicine, where the protective equipment, avoidance that you have to weighing balance between the risk and the benefit if the patient do the radiation. Sometimes we should stop radiation because the risk outweighs the benefit. And rescheduling that we can prolong, delay radiation if the risk is over the benefit. And shortening, meaning that we have hypofraction for decreased toxicity for the patient. And in daily practice, we can see that half of patients we have changed practice for radiation therapy. We can see here that we can see half a percent, 50% of patients we change practice. And now I would like to discuss about the impact of COVID-19 on systemic therapy. There were many changes in practice, such as reduced dose intensity and dose density, less number of cycles, and postpone or cessation. And there were many unanswered questions, such as how to treat the patient with organ failure after COVID-19, the interaction between anti-cancer treatment and anti-COVID-19 treatment, interaction between systemic therapy with COVID-19 vaccination. Fortunately, we have many trials to answer this. This data shows that if a patient be chemotherapy or chemo plus IO, there is an increase of mortality rates within 2 weeks. You can see here that the hazard ratio is 1.3 and 1.13. But remember that the number of the patients do chemotherapy and do the chemo IO only 27 patients, so that we cannot conclude that chemotherapy and chemo IO had negative impact on mortality of patients. Fortunately, we have the data show that there is no difference between the patient in hospitalization, ICU admission, and mortality for the patient treated with immune checkpoint inhibitor. There are some difficulties because there is similarity between immune response adverse event for the patient treated with immune checkpoint inhibitor with COVID-19 symptoms. You can see here fever, dyspnea, cough, conjunctivitis, diarrhea. We can misunderstand with immune checkpoint adverse events with COVID-19. We look back in the past. There is some recommendation that we have to spacing out the interval between maintenance infusion for the patient with excellent response with immune checkpoint inhibitor, or do not hold TKI for COVID-19 patients with excellent response with TKI. And now the very important question that how vaccination in patients with lung cancer. Fortunately, we can see here the vaccine response is very good in the patient with solid tumor, but a lower response for the patient with hematologic malignancy. And you also can see here that messenger RNA vaccine had a very good response for the patient with lung cancer. For lung cancer patient treated with immune checkpoint inhibitor, we know that immune checkpoint inhibitor impact on immune system. So we worry very much about the efficacy, the vaccine response for the patient. Fortunately, we can see here that there is no difference in vaccine response for patients treated with immune checkpoint inhibitor and patients without treatment with immune checkpoint inhibitor. As well as that there is no difference in adverse event. In conclusion, COVID-19 pandemic has had significant implications on the treatment of lung cancer patients. Many lessons we learned from the pandemics for the future. Thank you for listening.
We will now move on to the question and answer session. May I please invite the speakers of discussion 1 on stage, please?
Now Q&A for discussion 1. We received some question from the audience. The first question is, what is your thought, the response and survival benefits of KRAS, the 20C lung cancer patient compared to EGFR TKI? 40% response rate seems have a room to grow.
So the question is, so this is very nice microphone. Yeah, the question is, do I think to improve this result? So this is a very difficult question, but if you did the in vitro experiment using the siRNA, which inhibits the expression of the KRAS, mutated allele of the KRAS. If you do such experiment for the EGFR or ALK, the killing is very efficient. But for the KRAS, some cell lines with KRAS mutation are not be killed by these treatments, meaning that oncogene addiction of the KRAS is in general smaller compared to the other oncogene drivers. And some papers said if the tumors show the EMT, which is epithelial mesenchymal transition, shows less sensitivity to the KRAS inhibition, including the small molecule or shRNA treatment. So one thing is you have to select the patients more efficiently. So not all the KRAS mutated tumors are responsive to the KRAS treatment. So that's one. The other thing is, as many researchers, many companies are thinking that the combination with the other treatment strategies, such as I showed earlier, the combination with chemo or IO or other small like SOS1 or CYP2. But so far, this combination strategy are not working very well. So it's very difficult. But KRAS is such oncogene, I think.
question number 2 for you.
Question number 2 is which one? Second one. What is the role of antiviral therapy for COVID? So that's your question.
Yes, sir. Number 2.
And this one?
Yes.
Oh, interesting concept of IO plus KRAS G12C, but it is still disappointing response. Do we have any subgroup which can be more beneficial to this combination, such as squamous cell, smoker, and male patient? This is, again, a difficult question, but my opinion is, in general, the KRAS mutation is not so frequent in squamous cell, so you cannot select by the histology, but smoker and male patients may have the higher mutational burden. And also, there are some reports that depending on the occurrence of the core mutations, such as KEAP1 or LKB1, it's inhibitory to the activity of the IO. So maybe the patient selection is one. Also, the PD-1 expression may be relevant in this situation too. So this kind of the patient selection is one, but it's very difficult to raise the activity for those patients whose PD-1 expression low or LKB1 KEAP1 mutations.
So the next. What is the roles of antiviral therapy for COVID when the patient receive TKI, EGFR TKI or chemo for Dr. Khoi?
I don't have data about this, but I think that we have to balance between cancer treatment and the need of COVID-19 treatment. If the cancer, lung cancer is progressive disease, I think the first thing I have to do is chemotherapy or immunotherapy or EGFR TKI for the patient immediately. If the patient, the lung cancer patient, is not a progressive disease and COVID-19 is very severe, I think that antiviral is the first thing I have to do for the patient. Thank you.
And the next question, the criteria to select the patients to upfront first, second line, and second and third generation EGFR TKI, especially in experience from Japan.
Yeah, okay, so it may depend on the availability of the drug, but in general, the international guideline recommend third generation EGFR TKI as a first line treatment. So, but some people think that the sequential treatment, for example, the first line afatinib followed by osimertinib may prolong the PFS by the TKI, so the two TKIs. But in this case, the patient has to have the T790 mutation, and those who don't, who be treated by the osimertinib, so they may miss the chance to be treated by the osimertinib. So I think the short answer is osimertinib is recommended, but if you can predict that this patient will develop the T790, then maybe the first or second gen followed by osimertinib may be better treatment, but it's again.
Osimertinib is a reimbursement from the government. Reimbursement from the government for osimertinib.
In Japan, you mean?
Yes.
Yes, it's free reimbursed, but it's very expensive drug.
So the next, is there any labs which is capable of test method application is for doctors?
Yes, so I think the foundation one or this kind of CZP panel may provide information on the copy number of the met. So yes, some, but it's also expensive.
The next question is for Professor DSU.
So with insertion EGFR exon 20 insertion, the combination of the immuno or chemo should be the first choice. Yeah. So far, only the approved drug in the United States is amivantamab and mobocertinib, and none is approved in Japan. So, but as I showed you, that the efficacy of these drugs are not so great compared to the other TKI therapy or other targeted therapy. So people may think about the combination again, like in the case of the KRAS. But as far as I know, they have not shown the very nice efficacy of this combination therapy. But certainly, this strategy should be sought in the future.
The next.
What are the molecular tests to perform in newly diagnosed lung cancer? So in general, again, the guideline recommends the simultaneous testing of the multiple testing of the possible 8 or 9 oncogene drivers. But it again depends on the availability of that test. So in Japan, about, I think, 50% of the newly diagnosed non-small cell lung cancer are tested by the multiple gene testing, including those 8 actionable mutations. But for Asian people, we have to think about the importance of the EGFR, because the EGFR is very frequent, so that we cannot miss the EGFR. So sometimes multiple gene testing using the next-gen sequencing technology is demanding. They require more samples, more DNAs, and sometimes that test may miss the EGFR, so which is very big loss. So we have to be careful not to miss the EGFR for the Asian countries.
Yeah, thank you, Professor. So the next question for Dr. Ko is we were sharing about the COVID-19 vaccination roles of advance in lung cancer and other cancer.
I think that the role of COVID-19 vaccination in patients with advanced and metastatic lung cancer is very important in compared with a normal person because the patient with metastatic and advanced lung cancer patient, if they had COVID-19, he or she in the state of very severe. And on the other hand, we know that the response of vaccine in cancer patients is very good. Thank you.
The next question is, in case a patient with a rare mutation, KRAS, HER2, which optimal approach, TKI or IO?
As a first-line treatment. Yes, so maybe the KRAS tumors, I think the KRAS G12C inhibitor, sotorasib, is approved only for the second line or later. So now we can do the chemo IO or IO alone for the KRAS with PD-L1 more than 50%.
How about the patient with ROS1 positive and PD-L1 over 50%?
ROS1, you mean?
ROS1.
Yeah, so in the case of the ROS1, the TKI is very active, and also I think that the ROS1, HER2, EGFR, so those are the frequent in the non-smoking population, has I think the lower response to the IO drug. So I think that in this case, the ROS1 TKI should be used as a first-line treatment. And for the HER2, it's like EGFR, so again, more frequent in the non-smoking population, but HER2 inhibitor is not so active, right? So it's very difficult decision, but I don't think there is a direct comparison between the HER2 inhibitors with.
We are continuous. What is treatment strategies for patients with core mutation carry sensitive EGFR mutations?
I think that co-mutation may mean that the P53 or MET or other things. So that, depending on the co-mutation, I think the strategy can be different. So if the co-mutation is like MET amplification or rare gene fusion, then ideally the EGFR-TKI plus MET inhibitor or other TKI may work. But if in the case of the P53 or P3CA, we don't have the targeted therapy for those. And some reports said that the people with EGFR plus P53 is worse compared to the without P53 mutation, but we don't know how to cope with this kind of the co-mutations.
How about the patient with EGFR positive and ALK rearrangement positive? ALK positive and EGFR positive, two drug are sequencing. EGFR mutation and ALK rearrangement. ALK.
Oh, so but I don't think it's common, right? So the EGFR is usually those kind of the oncogene mutation is exclusive each other. So that if you find the EGFR, people do not have the ALK and ALK. So usually, but as a
in my daily practice, there are two patients with ALK positive and EGFR positive.
As a resistance mechanism, ALK fusion may emerge. And in that case, if you really have the patient with both EGFR activation and ALK activation, I think that ideally you can use a combination of these two drugs, EGFR-TKI plus ALK-TKI.
Concurrent. Yeah.
But it's not will not be reimbursed, but scientifically, I think that's a rational approach.
In your presentation, you didn't mention about the PI3K. The question is there any advance in treatment?
Yeah, so the PI3 kinase mutations are relatively frequent, even before the treatment, I think, in the lung cancer patient. But I am aware of the development of the PI3 kinase inhibitors, especially in the breast cancer or other type of lung cancer. But I have never seen the results of the combination of the PI3 inhibitor with EGFR-TKI. But in general, the PI3 kinase mutation is also the tumors are not addicted to this kind of a mutation. So the efficiency of the treatment is not so great. That's my guess.
Thank you. The next question is for lung cancer patients. What is optimal COVID vaccination schedule?
A very basic question, but I'm sorry because I don't answer the question.
The question is the patient has a squamous cell carcinoma and also have EGFR mutation, L858R, and PD-1 100%. The patient received osimertinib, but bad response. What do we think about TKI in squamous cell?
Yes, so it's very important questions. And so in general, the EGFR mutation in squamous is rare, but sometimes you find the squamous. And many cases, those squamous is not a central type, it's a peripheral type. And if you biopsy those patients, you see only the squamous component, but if you resect that tumor, you may find the adenocarcinoma components. In that case, sometimes TKI works very, very well. But I know that some relatively exceptional occasion, the squamous, through squamous may have the EGR mutation. In that case, those patients are small. So those, I like to ask the question people who give this question. So is this patient a smoker or not? Smoker or not? Sorry? Non-smoker. Wow. but in general, the squamous patients are often smokers. In that case, the tumor has many more co-occurring mutations. So that may impair the efficacy of the TGAP. Maybe peripheral. Microphone.
Hello. The tumor is the peripheral of the right lung, and he had the metastasis in the pleural. Yeah.
Okay, thank you. So so my guess was osimertinib might have worked, but your case is sort of exception. But that tumor may have another oncogene addiction like MET amplification. So that's not, I mean, that's not a squamous cell carcinoma EGR mutation in general.
Okay, thank you very much for question and answer. And now, thank you very much for Professor Tetsuya. So we one more, the last question for Professor Mitsurumi. Do you think about EGFR exon 20 insertion at the extra C helix in clinical practice?
Yes, I think the C helix, alpha C helix, usually the EGFR exon 20 is helix, and that will rotate the C helix to the more active form part. So, but it's in clinical practice, I don't know.
So we finished the first discussion. Thank you very much, Professor Tetsuya and Dr. Khoi. Thank you for the question from colleagues. So now it's time for break.
Thank you very much.
Welcome back, everyone. And now we will move on to discussion 2 on how to maximize the treatment outcomes in EGFR mutation-positive non-small cell lung cancer, chaired by Professor James Young. Professor James Young is currently the Director and Distinguished Professor of the Graduate Institute of Oncology at National Taiwan University. He was appointed as the Superintendent of the National Taiwan University Cancer Center Hospital in 2020 and is currently serving as the Executive Secretary of the Taiwan Lung Cancer Clinical Trial Consortium. Please welcome Professor Yang.
Hi, everybody. Welcome back to our second session. So this session is about EGFR mutation positive non-small cell lung cancer. We have distinguished 4 speakers. The first speaker is Professor Yilong Wu. Unfortunately, he cannot be on site, but he is delivering the talk of upfront treatment strategy in early stage EGFR mutant non-small cell lung cancer. Professor Wu is world famous expert in lung cancer research. He is also was the chairperson of the Guangdong People's General Hospital. Now currently still serving as a very important lung cancer researcher in China. So he was established himself ever since 2000 to start many randomized clinical trials, and also was instrumental to establish CTONs, as we have seen that there are so many studies of CTONs that has changed our practice nowadays. So I think it is our great pleasure to welcome Professor Wu to present this topic. Professor Wu, please.
Hi, dear friend. Good morning. I'm Yilong Wu from Guangdong Lung Cancer Institute. Today, I give the talk about the unformed treatment strategies in early stage non-small cell lung cancer with an EGFR mutant patient. This is the disclaimer, and this is my disclosure. Today, I will talk to the topic, one topic, the current treatment paradigm in early stage EGFR mutant non-small cell lung cancer. The second, I will talk about the future perspective in early stage non-small cell lung cancer. For the adjuvant targeted therapy, the purpose of the adjuvant therapy is to eliminate micrometastatic disease after the surgery. For the resected non-small cell lung cancer patient with the EGFR mutant patient, we target the patient with the higher recurrence possibility and the most potential benefit from the adjuvant EGFR TKI therapy who are stage 2 or stage 3A, especially for the N1 to N2, the non-small cell lung cancer. The first report, the phase 3 trial, the adjuvant EGFR TKI based on EGFR mutant, was the CTON1104 adjuvant trial, which enrolled stage 2 or stage 3A, the EGFR mutant non-small cell lung cancer after the R0 resection. 222 patients were the complete reset, then the randomized in 2 groups, adjuvant gefitinib therapy or the adjuvant chemotherapy. The primary endpoint was the disease-free survival. The DFS was 30.8 months in the adjuvant gefitinib group versus the 19.8 months in the adjuvant chemotherapy group. The hazard ratio was 0.56. The median overall survival was 75.5 months in the gefitinib group versus the 62.8 months in the chemotherapy group, but with no significant difference. From this trial, we know that the adjuvant gefitinib can decrease the risk of recurrence for stage 2, stage 3, N1 to N2 EGR mutant non-small cell cancer after the R0 resection. Another similar design, the phase 2 trial, IMPACT, was conducted in the Japanese population. Adjuvant gefitinib versus cisplatin plus the vinorelbine for patients with the resected stage 2, stage 3 non-small cell lung cancer with the EGR mutation. But the outcome is different from the CTON-1104, although adjuvant gefitinib appeared to prevent the early relapse, but it did not prolong the DFS or the OS. This means that this is a negative clinical trial. The third clinical trial is called evidence. This is another same design phase 3 study, randomized icotinic or the chemotherapy as the adjuvant treatment for stage 2 to stage 3 EGR mutant non-small cell lung cancer in the Chinese population. Adjuvant icotinic can decrease the risk of the recurrence for the disease patient. 322 patients were enrolled. The median DFS in the icotinic group was 47.1 months, which was significantly longer than the chemotherapy, with the hazard ratio 0.36. Per the position data from the evidence trial, the Chinese regulatory department NMPA has approved the adjuvant icotinic in the stage 2 to stage 3 non-small cell cancer with the EGR 19 or the EGR 21 mutation in the China. The big one is the ADORA trial. This design was totally different from the CTON-1104. Randomized osimertinib versus the placebo for stage 1B to 3A non-small cell lung cancer with the EGR mutation after adjuvant chemotherapy. Update data at the ESMO this year Congress for stage 2 to 3A the patient. Adjuvant osimertinib can significantly prolong the median DFS 65.8 months versus 21.9 months in control group. The hazard ratio was 0.23. For overall population, stage 1B to stage 3A, the median DFS was 65.8 months versus 28.1 months in the control group. Hazard ratio was 0.27. Adjuvant osimertinib for stage 1B to 3A non-small cell cancer with the EGR sensitivity mutation after zero resection was approved by the FDA. Furthermore, for neoadjuvant therapy, we are targeting eliminated micrometastasis tumor and the screen case the tumor. The targeted patient will be the potential resectable non-small cell cancer with the EGR mutant patient. We are focused on the 3A2 and 3A3 the patient. CTON-1103, the emerging trial, was a randomized phase 2 study to evaluate the erlotinib versus the gemcitabine plus cisplatin as the new adjuvant treatment for stage 3A, the N2 EGR mutant non-small cell lung cancer. Same two patients were randomized into neoadjuvant plus adjuvant erlotinib or the GC chemotherapy group. The primary endpoint was the overall response rate. The overall response rate was 54.1% in the erlotinib group and the 34.4% in the chemotherapy group, which have the secret difference. However, the median DFS for erlotinib has achieved the significant difference with the 21.5 months versus the 11.4 months. In the new ADORA trial, EGR mutant resectable non-small cell cancer patient used the osimertinib without chemotherapy versus the chemotherapy alone for neoadjuvant therapy. The primary endpoint is the major pathology response at the time of the resection. And the secondary endpoint include the event-free survival, pathology complete remission, and so on. This study is ongoing. Based on this data, the ESMO expert consensus on the neoadjuvant TKI for the non-small cell cancer. Majority expert claim that there is current no data to support the neoadjuvant TKI for non-small cell cancer in overall or the borderline overall patient. In the second topic, we are going to look into the future perspective in early stage non-small cell cancer. One key question is how to choose a patient benefit from the adjuvant therapy. Another question is the beyond the EGFR mutant in early stage non-small cell lung cancer. How to choose a patient benefit from the adjuvant TKI therapy. The median one, based on CTON 1104, was the design to explore how genomic significance define the three subtypes with the distant adjuvant therapy outcome. According to the DFS, predicted value of the different genomic aberration derived into the negative adjuvant TKI predictor, the gene called RB1, and the positive adjuvant TKI predictor, including the NKS2, CTK1, and TP53 exon 41 mission. The MINOVA score, patient in the CTON 104 can be defined as the subgroup, means the highly TKI preferable, or the chemo preferable. High the TKI preferable account about 30% patient, and the DFS and OS in favor of the adjuvant gefitinib. Chemotherapy preferable group account 15% of the patient with the RB1 mutation, and the DFS and OS was in favor of the adjuvant chemotherapy, not the TKI. Another published trial regarding the value of the ctDNA was released at ESMO 2020 and conducted in Korea. It showed the longitudinal monitoring of the circulating tumor DNA from the plasma in patients with the curative resectable stage 1A to stage 3, the EGFR mutant non-small cell cancer. Near 300 patients with the sensitivity mutation were included between 2015 to 2017. Radiological follow-up, including the chest CT or the PET CT scan, was accompanied with the longitudinal monitoring of the ctDNA using droplet digital PCR. A significant difference was shown among the different targets at the baseline of the ctDNA copy number. Baseline ctDNA was detected in the 24.1% in curative receptor EGFR mutant non-small cell lung cancer. According to state of ctDNA, the 3-year DFS rate was significantly different among the 3 groups ctDNA negative at the baseline. ctDNA positive but the MRD negative, and both TDN and RD positive. These results suggest the patient with the baseline ctDNA positive and the MRD positive were associated with poor DFS in curative receptor stage 1A to 3A, the EGFR mutant patient. So we need to longitudinal monitoring for the curative receptor stage 1A to 3A non-small cell cancer in patients with this setting. How about the value of MRD? This trial was conducted in our institute and was published in the Cancer Discovery. 261 stage 1 to stage 3 patients were enrolled to receive the MRD testing. After median 19.7 month follow-up, the relationship between MRD and the DFS or the EFS, we understood the patient with the longitudinal undetectable MRD is close to cure. Longitudinal MRD monitoring was more effective than the single-time point detection. The detection of the MRD preceded the radiological progression by the median 3.4 months. Longitudinal undetectable molecular regular disease defines potential cured about population in localized non-small cell lung cancer. Next topic is beyond EGFR mutant in early stage non-small cell lung cancer. ALINA study is the compared adjuvant alectinib versus the adjuvant platinum-based chemotherapy in patients with the ALK-positive non-small cell lung cancer who received a complete resection. This study is ongoing. We expect the result outcome in the near future. This table review also summarizes some the ongoing the new adjuvant clinical trial on the driver gene, including the ALK, RET, MET, and this embryo clinical trial, including also many driver gene mutation. How about the adjuvant immune checkpoint inhibitor in early stage non-small cancer? As we all know, the IMPOWER 010 randomized some the patient with the EGFR mutation patient, but from this data, stage 1B to 3A, the non-small cell cancer, if the patient with the EGFR mutant patient, the benefit is the limit. Finally, is the summary of the today, the percentage. First, we are discussing clinical treatment paradigm in early stage EGFR mutant non-small cancer. In the field adjuvant therapy, the adjuvant oxaliplatin and the adjuvant icodine decrease the risk of recurrence. The indication were approved by the FDA and NPA. And in the field of new adjuvant therapy, there's a current no data to support the new adjuvant TKI for the NC for the non-small cell cancer in open low or borderline open low case. For the future, how to choose a patient benefit from the adjuvant TKI? Genomic signals can guide the benefit population. For the beyond the EGFR mutant non-small cell lung cancer in early stage, alectinib and another trial is ongoing. For the immunotherapy as the adjuvant, the DFS and OS only in Japan, but we have to know the strong evidence. That's all the topic. Thank you for your attention. Thank you.
Thank you so much, Professor Wu. We have a discussion session at the end, so let's move on to the next speaker. Next speaker is Professor Kang Jin Jong. Kang Jin Jong is from Korea, Professor of Medical Oncology, St. Mary's Hospital. Professor Kang, I guess he is on site. He's going to tell us novel treatment strategy in advanced non-small cell lung cancer with EGFR mutation. Please, Professor Kang.
Thanks for Professor Yang. It's just nearby to me. It seems to be very close to me. Anyway, I'd like to talk about the today's novel treatment strategy of advanced EGFR mutant non-small cell lung cancer. This is my disclaimer and my disclosures. As you well know, there are two treatment strategies sequence with upfront treatments in EGFR mutant non-small cell lung cancer. The first one is osimertinib upfront and then followed by chemo if there has some resistance to the osimertinib. And the second one is first generation or the second generation TKI. And when he treated these patients, and then if the patients has failed due to the acquired resistance to the TKI, and then we're going to do rebiopsy using the tumor tissues and blood, and then based on the T790 mutation, whether presence or not, we can select the osimertinib or the chemotherapy. That's the sequential treatments. And a third of the four at EGFR deletion 19 patients may have more than T790 mutation. That's based on all the literature's data. And this, as you know well, this is clinical relationals between each upfront treatment strategy. The left survival curve shows the FLORA study is third-generation TKI versus the gefitinib in first-generation TKI as upfront treatments. And this study shows a very superiority over survivor beneficiary compared to the first-generation TKI. The right survival curve is a sequential approach, a representative clinical trial, RS3. This clinical trial is randomized the patients with the osimertinib or the first-generation TKI, even the standard chemotherapy, and the patients who had failed to the first generation with second generation TKI and the upfront treatments. That's the sequential. To those, the landmark clinical study shows a superiority of the third generation TKI. However, if you carefully see the result of the FLORA study, this is the third generation TKI upfront study, the right panel shows to the subgroup analysis that the Asian ethnicity and LA5R shows there's a limited overall survival benefit in the two subgroup populations, as you know well. And these are Asian populations and the Chinese populations and Japanese populations. It's very obvious in the Chinese population, 1/3 of the composed of Asian populations, and the Japanese population is recruited 1/3 of populations among the Asian population. As you can see here, the Asian populations doesn't see any more the survival benefit as time goes by. It's such like in the 36 months and 40 months, and the survival curve is crossover. The Chinese population is very close, some of the slight superior to overall survival. However, as time goes by, the survival curve will cross over eventually. The Japanese population is different, the pattern of survival curve. The survival curve is quite different in the crossover. It's the earlier times, 25 and 20 months, the later from the administration of the TKI, the experimental drugs. Now I'm going to stress about the resistance mechanism as Dr. Pistoni already addressed. The left panel is T7 mutations as dominant resistance first to second generation TKI. The 50 or 60% and T790 mutation was found in rebiopsy tissues after the failure of the first or second generation TKI. But probably unknown mechanism, 20% is unknown mechanism. The contrastly, the right panel shows the third generation EGFR TKI upfronts. What happened in there is the rebiopsy tissue shows very heterogeneous, much heterogeneous resistance was found in the rebiopsy tissues, but even at the 20 or 30% has still unknown mechanism. Probably my lab as the research did the autophagy reflux trust, and it's somehow related with the EGFR resistances currently, and the data will be reported next year, 2023, the AACR meeting. And I have to move to the real-world evidence on the sequential treatment EGFR mutant positive advanced non-small cell lung cancer. Well, the geotech study is first real-world study on the sequential treatment EGFR mutation positive advanced non-small cell lung cancer patients. The Asian population at 24%, EGFR ECA performance then the 15%, brain mets patients was recruited at 10%. The sequential treatment with afatinib followed by osimertinib in the Asian population is great advantage of the survivors in those populations in time on treatments with the overall survivor. As summarized, the DUTEC study's final data shows for the EGFR mutant non-small cell lung cancers, the sequential of the afatinib followed osimertinib was very encouraging data, particularly for the deletion 19 with Asian populations. Those specific populations has strongest the potence, the improvement of the survival outcome in this 37.1 months over survival, 44.8 months, and the time on treatment 37.1 months in the overall survival, 44.8 months, especially 45.7 months in lesion 19 positive subpopulations. I'd like to just briefly summarize the RESET and TOAST study, which was driven by the Korea and validated geodetic studies with large Asian cohort, the Korean cohort. The RESET study and the TOAST study is just similar number of population and more than 700 populations. This RESET study screening failure at 413, TOAST study only the 20%, 24 patients. And I read to the TOAST studies, I read to TOAST study. The TOAST study is running to the nature treatment scheme as cohort A, B, C, D. As like you are the practice. And the cohort A is T790 and positive patients, cohort B is negative patients, cohort C is the unknown T790 mutation after failure to the first upfront treatments. Cohort D is still ongoing of the afatinib treatment without any other combinations. And these studies, the RESET study survivor and the TOAST study survivor outcome is very similar. And then the T790 mutations positive patient and 35.4% of months of the time on treatments over survival is not reached yet at the report time. But TOAST study is very similar result of the survival outcome in time on treatments. And see that. I just changed it to the Japanese real-world evidence and the CJLSG 903 studies. The first afatinib versus osimertinib studies, which is evaluate the efficacy of the osimertinib compared to the afatinib in clinical practice. They randomized the 559 patients to the afatinib and osimertinib, just not a prospective study, the retrospective studies. Afatinib has included 225, and osimertinib 329 patients. Primary endpoint and time to discontinuation, NETKI, TDT-TKI, and a second endpoint and overall survivor. This data was already reported at the ESMO meeting. The afatinib shows the promising is a real-world practice, and it shows the afatinib 18.6 months versus 20.5 months, and osimertinib a very similar, statistically insignificant difference. And a survivor curve at the second endpoint, and the time to treatments, progression-free survivor, and osimertinib. As you can see, his progression-free survivors, overall survivor is just the favor in the afatinib, and rather than the osimertinib. And this study shows afatinib consistently shows the powerful efficacy in the deletion 19 and L85R. It's just like the geotech studies, the result. The left panel shows deletion 19 and L85R. As you can see here, the L85R is just favoring the progression-free survivor in overall survivor in afatinib. It's just a slight difference from the FLAURA studies, the prospective studies upfront and osimertinib. And right panel shows the deletion 19 with brain met patients, very special subpopulations there. And you can see there's the afatinib. Also, this shows the beneficiary efficacy in the TDT-TKI, time on treatments, and rather than the osimertinib. However, PFS and OS doesn't mean anything, the difference in all. And what about LA5R, that without brain metastasis, as it shows, as all of these three overall survivor endpoint was favored in the afatinib rather than the osimertinib. The sequential approach, which is better to the first gen or the second generation TKI? The second generation TKI already know the broad inhibitions, irreversible binding to the TKI compared to the first generation TKI. And afatinib is already showed to demonstrate better efficacy than first generation TKI in the Lung 7 study. The left panel of the bar graph shows the afatinib as superior to response rate rather than the gefitinib in a total, and the deletion 19 on the LA5R, all the subtypes and the common mutations that shows the superior response rate of the afatinib rather than gefitinib. And also the survival outcome shows that afatinib is the superiority of the progression-free survival compared to gefitinib in 15 months and the 24 months, and it's 27% and 6% point of the progression-free survival, the superior to the gefitinib. I don't like just introduce the Taiwan, the real-world data. This data shows already the afatinib has the longer survival and better efficacy and compared to the gefitinib. Even the real-world studies, 3 companies is very consistent as the survival outcomes are superior than the first generation TKI. And also the Japan guys has the reported real-world data shows, and the multi-center retrospective study was done in the EGFR mutant non-small cell lung cancer who acquired resistance TKI in any line, the afatinib, versus first generation TKI. The median overall survival is 17 months versus 9.7 months, and the p-value is 0.164. There's no statistical difference over there. But in osimertinib first treatments, and the afatinib followed by the osimertinib, objective response rate at 82.9%, disease control rate 91.4%. However, first generation TKI followed by osimertinib is the lower objective response at 53.9%, disease control rate at 71.1%. 2 sequential treatments is statistically highly significant. Which populations can get more beneficially on the sequential approach with afatinib upfront? The higher proportion of T790 mutation, resistance mutations, in the deletion 19, which is compared to the L85R. You can see there the deletion 19 groups, the T790 mutation positive rate at 50.4%, and L85R subgroups, they which lower the T790 mutation positive rate to 36.5%. And there's a different the T790 registered mutation frequency and between deletion 19 compared to L858R. But I'd like to focus why the deletion 19 is L85R. Why is the difference? Nobody does give me the answer to the 2 different common types. Definitely all of the clinical trials, randomized clinical trial, is the deletion 19 is superiority compared to the L85R. The afatinib demonstrate overall survival benefit in deletion 19 patients compared to the chemo. Is this, you can see here, the afatinib is much better. The hazard ratios, the overall survival beneficially, LUX-Lung study and the LUX-Lung 6 study, as Dr. Young was conducted. This panel shows deletion 19. However, L855R doesn't have any difference of the afatinib was compared to the control arms. This is the geotech study. I drove back to the geotech study already. The overall survival in deletion 19 positive Asian populations upfront afatinib is definitely, obviously followed by the osimertinib as beneficially. As you can see here, the geotech study. In the overall survival deletion 19 patients in the median overall survival 41.6 months. In Asian with the deletion 19 positive 2 components combined there, 45.7 months median overall survival. And the LISA study also reinforced the same data, T790 mutation, afatinib followed by osimertinib, not reached yet, the negative patients, the almost 50 median overall survival rate has been reported. I'm going to talk about the clinical outcomes of the sequential afatinib osimertinib on brain metastasis. As you know, with the brain metastasis, very difficult disease areas. And when we treated the DKI, and sometimes very frequently the brain metastasis was found, the single, oligo, and multiple with different patterns. And overall survival in patients' brain mets and the geotech, the upswing study, a RESA study, also shows very constant median overall survival, 31 months, 29.6 months, 48.5 months in T790 mutation. That's when he treated afatinib with osimertinib, even the brain metastasis patients have, and then a consistent response rate is here. In the Korean toast data, Initially, brain metastasis in the EGFR mutant patients was found in the 38.9%, just like the 40% have already existing the brain metastasis. Just like the slight higher than other countries report, probably Korea has the much more the frequent brain MRI was prescribed in the initial diagnosis. And then they failed to the EGFR TKI first line, and then brain metastasis 10% up the grade, and more than half of patients have the brain metastasis and the failure of the EGFR TKI. Lastly, I just have one slide in the toast in CNS response rate with progression-free survival. And at the beginning of the afatinib treatment, 38.9% have brain metastasis, as already shown here, and CNS response cohort was 138 patients. Local treatment, 9 patients with pre-existing brain metastasis before afatinib. That's the defined definition of the CNS response cohort. And among them, in the 106 patients who has a CNS response assessed, CNS response rate, CR plus PR, was reported 67%, and median CNS progression-free survival in 24.7 months, just comparable to the flawless osimertinib data was the EGFR mutant positive with brain metastasis at the initiation treatments. Right panel shows CNS progression-free survival afatinib in local treatment patients with brain metastasis, quite remarkable with brain metastasis control outcomes. I'd like to make conclusions. Heterogeneous resistance mechanism of first-line osimertinib led to the limit available to second-line treatment options, and currently Florida data bring up to the question about the efficacy of first-line osimertinib for all comers in the Asian populations. Geotech, the RESET, TOAST, even the real-world studies, the strong enforcements, the evidence that upfront afatinib followed by the osimertinib can achieve the consistently prolonged the time on treatment over survival in Asian populations. Sequential approach with upfront afatinib is feasible and cost-effective therapeutic strategy, EGFR mutant positive non-small cell cancer, especially in those deletion 19 with brain metastasis Asian population. Thanks for my attention.
Thank you. Thank you, Professor Khan. Thank you for flying all the way to Hanoi to join our participants, especially from Vietnam. We have some time for discussion, so let's move on to the next speaker, Professor Tony Mark. I guess I don't need to introduce Professor Tony Mark because everybody know him, including aliens. Professor Tony Mark is from the Chinese University of Hong Kong. He's, I think he's emeritus professor in Li Shunfang Medical Foundation, and he's in the Department of Chemical Oncology, but he's not famous for this. He's famous for his IPAS trial. He's famous for his many other studies, including all driver mutations, immunotherapy trials that he has participated and led. So he is very kind today to give us a talk on emerging treatment strategy in advanced EGFR mutant positive non-small cell lung cancer. Tony?
Thank you, James. I actually certainly don't mind to learn some alien, you know, but I think first is let's start to get to know you first. So sorry that I could not come to Vietnam like Dr. Khan. Actually, I just come back from Paris and then I got COVID positive. So this is my first day outside, you know, of my quarantine. But anyway, happy to be with you virtually. So this is my disclosure. And then this is actually a free company that I'm actually on the board of directors. So emerging treatment, but emerging from what? Emerging from what Dr. Khan had told us, or emerging from something else? What are we emerging from? Well, we are emerging from multiple combination with either chemotherapy or anti-angiogenesis. All have proven to improve progression-free survival and selectively over survival. But to emerge from the so-called right now, the official standard internationally on the FORA study, looking at the median overall survival about 38 on 6 months. So that's what we need to emerge from, is that this is about 3-year-old survival that we achieve. How can we make it better? So that is to take on the overall survival to a next level. So what are the things we need to do to achieve that objective? So the first thing I'm going to talk about is that to know who may not do well. You have probably already seen Dr. Khan's presentation. There are some patients who did better than the other, such as the 19 may be better than 21, but is that the only thing that we look for? Second, what are the first-line options that we can increase? And then how to treat the osmotic resistance, but last but not the least, how do we put immunotherapy in the management of EGFR mutation positive lung cancer? So those are the 4 areas that I would like to discuss with you. So the first part is that who may not do well. Way back from the IPASS time, we know that there is a group of patients who actually did not perform that well, and there's equal efficacy as the chemotherapy. They are the 10% of patients who may progress and about 20% of patients who may only achieve stable disease. But is it so simple to say, is it 19 and 21? I'm afraid not. So who do poorly? There are some data. This is actually NGS about 180 patients with the first-line triflutinib from Beijing by Wang Ji, published in Lancet Respiratory. That he classified the 3 groups. For the first group is the patient with only EGFR mutation. The second group, which is a large group, are the patient with actually other tumor suppressor gene, the most common one being TP53, and then plus a few others. And then last but not the least is the group with the other driver mutation. Smaller group, but substantially persons of multiple mutation since the very beginning. So this is NGS before treatment, not after treatment. Okay, so prospectively, they looked at the survival, finding that the patient with EGFR mutation only got the best outcome. If they got a suppressor gene co-mutation like TP53, they are the second one, the blue line. And then the patient who do poorly are the one with the co-driver oncogene. So in a way, we know that patient with co-mutation is actually contribute to the eventual outcome. And it makes sense in a way is that there are tumor heterogeneity. EGFR may not be the only driver. The other predictor is that whether the patient may have residual plasma DNA. This is the FAST-2 data that we published almost like 6-7 years ago, together with a lot of my colleagues from Asia, that if the patient have the persistent EGFR mutation at cycle 3, then the progression-free survival and the overall survival are consistently better than for the patient who can clear off the plasma. So we can kind of predict who did worse. Now, so the question is that if you got a plasma that is positive, can we convert the treatment and make things better earlier? So that comes to the study this year in ESMO in September called the APPLE study. There are 3 arms. There are EGFR mutation positive patients. Arm 1 is go to osimertinib, arm A. Arm B is triflutinib, but then monitor the T790M in the plasma. If they are plasma positive, then they give it osimertinib. Part C is the triflutinib for using RECIST criteria at a progression change to osimertinib. So this is actually a very important conceptual study, is to use a plasma monitoring and change therapy. But there's a slight problem with the endpoint. The endpoint is a randomized but not comparative study. So, and then the primary endpoint is a progression-free on the osimertinib at the 18 months arm. So in a sense, is that we do not have any comparative data in this regard. The second problem is that the plasma DNA is measured by COBAS test version 2. Now, this is actually not the most sensitive testing for T790M. So let's look at the result. So approximately arm B, the one who used plasma monitoring, 60% had changed into osimertinib. But out of that, only 25%, meaning 1/4, are changed due to the plasma. The other 75% is changed due to RECIST criteria. So in other words, even in arm B, they only pick up a small number of patients who got plasma conversion, which is only 17% in general. So as a result of that, yes, you do have a reasonable progression-free survival, but you combine the of two sets of treatment. But then if you compare arm B and arm C, there's actually no difference in the progression-free survival. So in a sense, is that this is kind of a positive study, but does not give us any strong message in a way of how to do the intervention. So the future study had to use first line osimertinib, and then residual plasma DNA, and then intervention. So I think we still got a lot to do with the future development of plasma detection for the patient who may not do well early on. So the new strategy is conceptually correct, but we have not proven it with the Apple study. A lot more study need to be done in this arena. And certainly, I think among Asia, we should do this kind of study together. First line treatment option. Apart from osimertinib, which is the pyrimidine-based molecule, actually a couple momelotinib and fumonitinib. So I know that it's not available outside China yet, but there's a few important issues here. Number one is the fact that whether they're effective. Number two, if they're effective, and they will be cheaper because they are actually approximately 10% of the standard price of pyrimidine in China. Can we make it available to Asia? Because in a sense is that we do have a financial issue related to third generation TKI. Would this drug be available? So let's look at the data first. First of all, you look at the molecular structure of all three drugs, all fully similar. Now, it's not a me-too drug. Well, it's a me-too drug, but they are not a generic drug. But there are similarity of the molecule in a way that they're all pyrimidine-based. So this is the key to success of this molecule, is because it's pyrimidine-based and it's bind to the C797 as such. So if you look at the basic data from the T790M positive population in the phase 2 study, response rate is 70% and 74%. And the median progression-free survival is also similar at approximately 10 to 11 months. And so basically, there is actually similar outcome as a second-line treatment for T790M positive patient. If you look into the even CNS data, is also consistently in about 60 to 70%. From the single-arm phase 2 study, which is all published, they are similar. But in the first-line situation, there's a linear study that's published in JCO by Lucian, and Dr. C published in Lancet Respiratory, is the first-line randomization against gefitinib. You can see that it's a decent randomized study, 2-to-1 randomization for one, and then 1-to-1 randomized the other one. There is a significant difference in the progression-free survival in approximately 20 months, which is similar from what we reported in the FORA study. So in a sense, both in second line and first line, similar data. It's just that the drug is available only in China for the time being. Other alternative first line is whether we can combine with chemotherapy. This is FORA 2. The study is complete accrual, waiting to be mature. Now, so this data, when it becomes positive, if it is positive, are we going to use it? We have to wait and see. But right now, let's look at some of the prediction. If it is there's a Japanese study, look at the T790M positive population, osimertinib versus osimertinib plus chemotherapy, done in Japan, second line situation. There's absolutely no difference between progression-free survival over survival. Now, one of the reasons is this, is that in the other study, the CNS may be a major problem, but then with osimertinib, CNS control is good in either cases. So right now from the small Japanese study, we don't have a signal, but we have to wait for the FORA 2. A combination for anti-androgenous is a FORA 3 is also being done, and then there's the data waiting to be seen. And again, if you look into the Japanese data, a phase 2 study on the T790M positive population, there's actually no significant difference in terms of the progression-free and over survival, except in the avid smoker, there seems to be some benefit. So there's where we are for the first line as a potential new option that we can consider. Resistance is a major issue. After 18 months, 19 months, we'll have the resistancy, what to do. Of course, the C797S is important because that is the site of the binding. And Raymond Lingham in WCLC looked at the incidence of WCLC and the incidence of C797. And you can see that it has progressively increased over time. This is actually the first evidence of dynamic changes. So over time, you will get higher incidence of the C797F. followed by CCNE1 amplification, and followed by MET amplification, which I'll talk about in just a moment. So how are we going to treat with it? Well, this year, there is a Korean medication called the BPT-176 that's supposed to be able to inhibit the C797 positive lung cancer. This is a dose escalation study reported in the WCLC. Now, you can see that they have 8 patients with C797S out of their PR and 5 SD. And then the patient who got SD and PR, they are the one who had actually a durable response. So early signal, not a strong signal yet, but then we have, this is where we are. What about bispecific antibody? We can combine amivantamab with lazertinib, which is a Korean-made 3rd-generation TKI. Now, so this combination was studied in the Chrysalis study and demonstrated a response rate of about 33%, median progression-free survival almost like 10 months, almost 8.5 months. And then this patient are so-called the heavily pretreated population. So right now, a randomized study, the Papillon study, is actually ongoing at this moment, and we have to wait for the final result. For the MAC, this was actually recently published in Cancer Discovery of the TETAN data. That is on patients who had MET amplification after 1st or to 3rd generation TKI. Part B1 is on the 3rd generation TKI, which is the osimertinib. Part B2 are the 1st and 2nd gen TKI with MET amplification but T797 negative. Part B3 is T797 positive. Now, focusing mostly on what they mean by MET amplification. They use a FISH over 5 times, IHC 2+ or 3+, and NGS over 200 by definition. So for that, I think the key observation is the fact that if you are osimertinib failure, MET amplified it, and go on with osimertinib plus savolitinib, this MET inhibitor, you will have a response rate of 33%. Now, early preliminary data, but important is that this year in WCLC, there's also Savannah study, which is a large size 196 patient on savolitinib plus osimertinib. Sorry, there's some Chinese character, but then the key matter is this: the overall response rate is actually 32%. But then more in the patient who are IHC 90 or the FISH over 10, your response rate is getting up to about 50%. Now, this is actually quite remarkable. In a way, is that the cutoff can be variable. The higher the cutoff, the more likely you're going to have response. And also the patient with the low MET amplification, the result is actually very poor with only 9% response rate. So this is a single arm study. And the important thing is that we have a randomized study ongoing right now called the Saffron study run by AstraZeneca. And then over 274 patients, MET plus is actually by central IHC at 3+, with the FISH as a so-called a second biomarker, randomized to osimertinib plus savolitinib versus standard chemotherapy. And certainly this will be an interesting study. Now, besides that, this year there is a combination of tepotinib and plus the osimertinib in the MET amplified population, and also report a high response rate, about 50–60%. Now, ADC is another direction to go, and this one is actually on the use of a drug called patritumab deruxtecan, and then published it by passing on in Cancer Discovery. It's a phase 1/2 study, total about 57 patients. And then the response rate is about 39%, median progression-free survival 8.2 months, and overall survival not reached yet. But then there's no specific biomarker, but the data is encouraging enough such that we're going to engage a phase 3 study, which had just been initiated. It is for EGFR mutation failure with exposure to osimertinib, randomized to patritumab deruxtecan versus standard chemotherapy. It's called Athena study. This study is also involved in Asia, so certainly your participation will be highly appreciated. Last but not the least, I would capture on the immunotherapy. So, IMpower, we have engaged in the clinic, but the sample size is only 58. It is a small subgroup analysis from the large randomized study, Total number is about 108 patients, but for the four drug arm and the free drug arm is about 58 patients. So we cannot change the practice based on this. So what we need to do is look at other data. One study is called the Orion 31. That is on the mutation positive again failed TKI. Arm 1 is the cetirizumab plus anti-angiogenesis, a biosimilar bevacizumab plus the chemotherapy. Arm B is cetirizumab plus chemotherapy. Arm C is actually Arm A and Arm C. Data was reported last year showing that there is improvement response rate 44/25% and progression-free survival of 6.9 months was 4.3. So the sample size is not bad, 150 patients in each arm approximately. However, in this year, they actually come out on Arm B versus Arm C. That is on chemo plus the cetirizumab versus chemo in a mutation-positive subgroup. This is only about 5.5 months versus 4.3 months. Response rate, 35% versus 29%. So kind of positive, but not strongly positive. So what should be the best approach? Well, I don't think we have the conclusion at this moment. So at this moment, we should actually wait for more data to come out from these two studies. One is a CheckMate 722, which are the patient who got mutation-resistant chemo plus levo versus chemotherapy. And then the other one is Keynote 789, again, similar design with the chemo pembrolizumab versus chemo. So all this will become supporting data of how we can utilize immunotherapy. And CheckMate 722, James and I are actually collaborating on this one, and it will be presented this next Asia. I'm dying to tell you the data, but certainly I would be dead if I told you the data. So I cannot tell you right now what the result is. But please watch out for CheckMate 722 in ESMO Asia Presidential Symposium. IMPOWER 151 is similar to IMPOWER 150 using Alimta, Cabo, pemetrexate, and bevacizumab and atezolizumab. And so there will be 50% of population, which about 150 patients or more that are EGFR mutation positive. So this data will also be supporting. So until then, I think we're still doubtful. So to summarize, I think what we need to know is that who may or may not do well, including the co-mutation, including the residual plasma DNA being positive. We have increase of more first-generation TKI and potential combination with osimertinib has to be entertained, but then data will come out soon. Resistance, we got multiple options targeting C797S with a Blue 947, BPT 176, other non-specific biomarker, including targeting the MAC with the MAC inhibitor, or amivantamab plus osimertinib, or we can consider use of ADC. Immunotherapy, whether it should be chemo plus IO, or chemo plus IO plus anti-angiogenesis remain to be seen. We will have 3 study data coming up, including the CheckMate 722, Keynote 789, and also IMPOWER 151 to support us. So thank you much for the invitation, and certainly I look for the future visit to Vietnam. Thank you so much.
Yeah, Fo. This is what we like most. Okay.
I like the Taiwanese beef noodle as well. I'm not, discriminating.
Well, we like all of them. So let's move on to the fourth talk. Fourth talk will be given by our local speaker from Vietnam, Dr. Tai Hoa. Dr. Tai Hoa is the head of oncology department from K Hospital, Hanoi. And she's graduated from Hanoi Medical University, where she also learned her Master of Oncology. And she's now working in the National Cancer Hospital. She obviously is on site, and she's going to tell us how best to utilize the real-world evidence in advanced EGFR mutant non-small cell lung cancer. So please.
Chairman, welcome to all of you to the 6th DSU in Hanoi, Vietnam. You know that guidelines as well as our practice based mostly on the data of RCT. And how about the role of real-world data? So how best to utilize the real-world evidence in advanced non-small cell lung cancer with EGFR mutation is my topic today. This is my disclosure. In my presentation, I will focus on overview of treatment goals and RCT data in treatment of non-small cell lung cancer with EGFR mutation, gap between RCT and clinical practice, and real-world data of afatinib in the treatment of non-small cell lung cancer with EGFR mutation. In practice, many patients with advanced stage non-small cell lung cancer will come with symptoms due to their primary or metastatic tumor. So the first goal of treatment is tumor response, I think. And the other very important goals of treatment is PFS, OS, as well as quality of life. Along with the advancement of medicine and technology, personalized treatment have replaced traditional approaches. So it is individualized treatment based on many patients' factors, including genetic results, to enhance treatment effectiveness and reduce toxicity. In advanced stage non-small cell lung cancer, there are effective treatment based on mutational profile. And one of the most interested group is the EGFR mutation positive. In RCT of EGFR TKI as first-line treatment, you will see here both first and second generation of TKI show better PFS versus doublet chemotherapy. And in the Lung-7 and Flora RCTs compare head-to-head different TKI generation, and both trials confirm the benefit of PFS of first and second generation compared with first generation TKI. But in the OS, there are no significant difference in OS in subgroup Asian and L858R patient in Flora. In terms of AE, there are different in each group of TKIs. You can see diarrhea and rash are rather common in patients treated with afatinib. And gefitinib have a highest rate of liver dysfunction. And we all know that when we treat patients with osimertinib, we have to pay more attention on the QT prolongation rate and LID-like event. So in clinical practice, there are group of patients cannot meet strict criteria of RCTs. So there are still questions in the clinical practice that haven't had answered yet, such as how effective are EGFR TKIs in different types of mutation, common and uncommon mutation, and EGFR TKI effectiveness based on patient characteristics, especially elderly patient, Asian patient, and how to handle AE and dose adjustment can influence the effectiveness of TKI and effectiveness of sequential treatment. So I would like to offer these following ideas to illustrate the role of real-world data. In terms of type mutation, you can see that in the data, in the available data, patients have L858R mutation have very poor, or not very poor prognosis than patients have Del-19. So this is the real-world data show the superior effectiveness of second generation TKI versus first generation TKI in L858R population. And in Japanese study also show the 858R subgroup, the second generation of TKI has encouraging results compared with third generation TKI in terms of PFS and OS. Data also show the higher proportion of T790M mutation at acquired resistance was observed in DEL19 than L858R. So this group of patients have more chance, more opportunity to get the sequence treatment, afatinib followed by osimertinib. And in the George Swing G data, you can see that the patient have T790M positive and DEL19. You can see the OS can reach 63.5 months. Uncommon mutations are still lacking in the data, in RCT data. So therefore, we will find the answer in real-world evidence. Pool analysis to assess the activity of afatinib and in 1,023 patients harboring uncommon EGFR mutation and other compound mutations show very high response rate. And in every group of this pool analysis, you can see that MTTFs of second generation TKI is longer than 10 months and up to 16 months. Another aspect of clinical practice that we need to consider is dose adjustment. And the result of the LAC-Lung7 in this, this is a RCT, but in the afatinib arm, there are 63 patients have dose reduction from 40 milligrams. And the data show that the dose adjustment cannot influence the efficacy of treatment and can reduce the toxicity of treatment. In our hospital, we also conducted the real-world study in which there were nearly 80% of patients have the starting dose 30 milligrams per day. And the dose adjustment depends on patient tolerance. And the result, there's no significant difference in TTFs between the two groups, adjust and non-adjust dose. About the sequential treatment of the TKI, this real-world study, GeoTac, have mentioned clearly by the previous speaker. So I just focus on the result of this treatment. You can see that in the group of Asian patients and Asian patients with 19 positive, DEL19 positive, we will have the OS results very impressive with 45.7 months. And other real-world data will show the efficacy of afatinib in this group of patients with DEL19 positive and Asian patients. And in the RESET and TOS study, we can see that even the patients don't have T790M mutation, the sequential treatment afatinib and then followed by other treatment than osimertinib can reach the OS as 38 months. So in summary, real-world evidence confirms the efficacy of EGFR TKI in non-small cell lung cancer with EGFR mutation. And real-world evidence has filled the gap between RCT and clinical practice. OS of sequence of afatinib followed by osimertinib was encouraging. And afatinib showed the good result in the whole population as well as special population, like uncommon mutation and Asian patient. And afatinib dose adjustment improved the tolerance without affecting its effectiveness. So that's all my presentation. Thank you for your attention.
Thank you, Dr. Zhang. Now, we have some more times before lunch. for question and discussion. So do we have any question from the audience present or any questions online? Here, I don't see any questions pop up from the Q&A. Perhaps I can raise one question first for our experts first. We know that FLORA was designed to demonstrate that osimertinib is better than erlotinib and gefitinib. Yet in the comparator arm, afatinib was not there. So would this be different if afatinib was included in the control arm? Let me ask Yilong first. What do you think, Professor Wu?
So I think the first generation, the second generation have some different target. The first generation TKI, that's only focus on the EGR mutant patient. But the second generation, that's the broad target patient, including the EGR, the implication, and another patient. So in clinical practice, when in the clinical practice in the Chinese guideline, we are consider if the patient is the EGR mutation and the EGR implication or the another such as EGR implication and so on. So in this situation, we are suggest the patient use the second generation TKI, including the afatinib and the dacomitinib. So I think this is one point. And also we have also some real world data that suggest for the exon 21 the mutation and the code mutation. So we could use the second generation first. Yeah.
Okay, Dr. Kang, on site. So go back to my previous question. Do you think that FLORA data will substantially change if afatinib is designed as a control arm as well, in addition to gefitinib and erlotinib?
Maybe I thought if the afatinib is inserted to the control arm, maybe I thought yes, the statistical difference might be different comparing to the osimertinib with afatinib in the subset of LA5R or the Asian population.
Mm-hmm. But the primary the PFS for afatinib is roughly 12 months, 13 months, and it's still far from 16, 17 months, right?
Yeah.
As a first line treatment.
Yeah, as you can see here is the real world data, all of the reference data shows the especially LA5R it's my bias. It's just slight different disease entity comparing with deletion 19. Okay. I told you the two evidence already shown. First one is LA5R is just one base substitutions comparing with the 15 to 19 base deletion in deletion 19. However, in the protein structure basis, LA5R is much greater configuration changes, which means at the TKIs, the ATP binding pockets in LA5R, much greater changes. As you can see, already see the straight 5 is the receptor in the pictures. However, in vivo conditions, LA5R is much movements, much changeable than deletion 19. That's why even the same TKIs bind to the LA5R. Is my bias is much greater configuration changes. It easily binding affinity is decreased. That's the decreasing of the progression survival or the other treatment outcome.
Okay, anyway, Tony, what do you think?
Yeah, I think I just emphasize on the two aspects. I don't think there will be a tremendous difference apart that we have adjusted the statistical sample size. I think it's not just a progression-free survival. We have looked at the CNS control. I certainly don't think afatinib can give you the same degree of CNS control. And also, look at both afatinib and dacomitinib data, the toxicity will require dose reduction, while the toxicity of osimertinib is a bit more tolerable. So I doubt if there will be a huge difference, but then of course that, about the subgroup, as Dr. Khan said, there may be some variation. Anyway, I don't think anybody's going to do it anyway, so it doesn't matter.
Right. It is probably something that we are looking forward to. Somebody may want to do that, but I doubt. Let me see if I see any question here.
Hi, Professor Yang. I have a question to you. Somebody, somebody gave us.
You cannot give question to me.
I'm just questions to everybody. So somebody previously questions to Dr. Mitsunomi is what is the selection criteria for whether the upfront osimertinib or the afatinib in EGFR mutant positive patients, and that answer is just the country's reimbursement guideline. That's the answer. However, in my viewpoint is brain metastasis, multiple brain metastasis, or the tumor disease burden is high and initial diagnosis, I definitely prescribe to the osimertinib, or the very elderly patients and just of the compliance of the TKI. That's my bias to the prescribe to the osimertinib.
Okay, so this is your sort of clinical selection based on all the studies as well as prior experience to select elderly patients, patient with large tumor volume, as well as patients who had brain metastasis to start with osimertinib. And you're asking me what criteria I'm using to select that. Of course. Number one is reimbursement. If patient has reimbursement, certainly we'll go for osimertinib. If there is no, then it's not the issue. But I think let's take insurance guidelines away and to think in scientifically whether we have good criteria to select one or the other. First of all, I believe that there are certain brain activities in afatinib. So this is not unlike a disease that is not controlled by afatinib. Afatinib also have some, even gefitinib or erlotinib, we know that they have some control over the CNS. The question is how long, right? So for patients who had CNS metastasis, if there was oligometastasis and patients are willing to use afatinib, we will use it and we see what happened. Remember that nowadays we sometimes do stereotactic for oligometastasis of the brain. And we certainly it's probably not appropriate to do whole brain, but for stereotactic, to ablate the oligometastasis, I think certainly this is something that we can do to increase the benefit of first-line EGFR TKI, even with osimertinib. And for elderly, of course, you will be amazed that in elderly population, the toxicity actually was not that different in afatinib compared with a younger population. Not sure why. But obviously, if you compare to osimertinib, afatinib is much more difficult to be used for elderly patients because they have some additional organ function to be considered. And for patients with bulkier disease, I actually have no reservation to use afatinib as well, because I think afatinib also have 90% disease control. So I actually have very little concern that we can use afatinib. The only thing that I think what Professor Wu had presented was to use genomic analysis, or Tony has also alluded to that, to select patients. If you have multiple mutations, for example, And in the first NGS data, perhaps you want to start with something that's more aggressive. I'm not sure whether osimertinib at this moment is better than afatinib, but it's certainly worthwhile looking at. But if you have, if fall into that poor performance category, certainly, in my belief, adding chemotherapy may help. But so we hopefully we can analyze the FLAURA data, FLAURA2 data, and we have enough tissue for that kind of analysis to tell us whether our hypothesis is right. So Professor Wu, what do you think?
Yeah, I agree with the opinion, but in the clinical practice, I think the first generation TKI, the second generation, or the third generation, all were recommended by the guideline, but only the osimertinib, this is a preferred recommendation. So I think that in clinical practice, we could use the osimertinib as the preferred recommendation, but based on the Chinese data and the NGS data, we have the need the subdivide the patient into the different subgroup, and then based the subgroup, then give the patient the different treatment. Thank you.
Tony, what do you think?
Yeah, I think that I should not say too much due to conflict of interest. So why don't we just other question? There are a couple other questions on the website that is kind of interesting. It's up to you to choose which one to address.
Okay. To Tony, while waiting for the result of FLAURA2 and FLAURA3, what is FLAURA3? For patients who... What is FLAURA3?
FLAURA3 is osimertinib plus bevacizumab.
Okay. For patients who are on OC first line, but the disease does not respond as expected, and the ctDNA and NGS is still positive, could we add, or should we add OC plus chemo plus bevacizumab in combination? Did you do this before?
Yeah, so if patients really do not do well in terms of the definite radiological progression, I may consider adding chemo. Not bad, because I think the data is not as strong that we have so far. But adding chemo, it makes sense in a way is that we do cover some of the so-called resistant clone. I may still continue with osimertinib, contrary to the IMPRESS study. It's mostly for the CNS protection. So especially for the patient who got brain met, I'm very reluctant to stop the osimertinib, but I will definitely add on chemotherapy. So in a sense, is that even the FLAURA2 will not be able to give us this answer, because FLAURA2 is upfront, it's not at the resistant clone. However, I mean, my common sense approach is the fact that if it doesn't do well, we got to do something, and then adding chemotherapy is one thing. But of course, we have to do biopsy, looking for MET amplification and others, and that which may help us to select the other resistant medication as well. So that's my approach.
Yeah, Tony,
yes.
In this situation, I think, do you continue the osimertinib plus the chemo or only the chemo?
Yes, that's again a good point. The IMPRESS study towards not too, but the IMPRESS study is with gefitinib, does not have the CNS benefit. So for the brain, if the patient has brain met, I definitely will continue osimertinib. With no brain met, I will just stop and observe the brain very carefully with MRI.
Yeah, I guess that is also my approach. Of course, OC, well, first of all, this is probably mostly financial burden, because osimertinib at that moment is not going to help too much for systemically. For brain, obviously, we can't watch that closely or continue osimertinib. So anyway, we move to the next one. In Apple study, there may not there may not be additional benefit to start first generation TKI sequential treatment, when you see the first cell-free DNA result of T790 and positive mutation, do you quickly initiate third generation TKI second line or revalidate with tissue biopsy results? Do you believe that the plasma can tell us everything? Tony?
Well, let's hear Dr. Khan first, and then I'll give my comment after Dr. Khan.
Dr. Khan, please.
I have a small little the experience, but that's why it's based on the liquid biopsy. I have some confidence of liquid biopsy T790 mutation. However, at that time, in my experience, I do the rebiopsy to the tumor tissue, and then I wanted to confirm the T790 it theirs, and then I change it to the treatment.
Yeah. So to me, since osimertinib is a standard first-line treatment, so if I got someone who are actually known T790M in the beginning upfront, I would definitely consider osimertinib. But now I'm talking about someone who initially don't have it, but subsequently I find it in the plasma. So under the same rationale, I think it's reasonable to use it in a way of hoping that there will be a longer progression-free survival rather than waiting for radiological progression. So I don't think the EPO is strong enough to support us to doing that. But because the osimertinib is already approved the first-line drug, I think it is reasonable to consider this alternation.
Professor Wu?
Yeah, so I think the T7 and the positive in the plasma, I think this is so-called the primary resistant. So in this situation, I immediately switch to the third generation TKI. I don't need the tissue biopsy.
Yeah, yes, of course, indeed, patients who had positive tissue and negative plasma, they tend to have a lower tumor volume, and positive T790 in the plasma, that means you probably already have a big tumor volume. So maybe a good candidate to start osimertinib right away. Let's see, there is another question. How about professor's opinion of using afatinib or other TKIs concurrently with local treatment like gamma knife or whole brain irradiation in brain metastasis? So this has been done before. What is our experience? Start with Professor Wu.
Yeah, so this situation means that the patient in initial diagnosis with the brain met. So in this situation, I think we prefer the osimertinib, not the first of the generation TKI. But if the patient, the treatment long term in the first or the second generation, then the develop the brain met. So in this situation, we could combine the local treatment with the gamma knife, the surgery. I think this is the different scenario. Yeah.
Okay. Do you think similarly, Tony?
Well, yeah, I think we should avoid whole brain ILT by all means. But then, if you use a gamma knife just on the active lesion, there is a good chance that there will be other brain met coming up. So if there is already an option of osimertinib giving you better CNS control, why not take that advantage? So in a way, it doesn't make sense is that you use, you're consistent to use a drug that's not such a good CNS penetration, but utilize the radiation, which will not give you the complete of the control of the situation.
Okay, let's move on to the next question. May I ask Dr. Huang on which dose afatinib to initiate treatment in our practice, 30, 20, or 40? Dr. Huang? Nguyen, Dr. Nguyen.
In my practice, I usually start with dose of 40 milligram. But in a patient who has poor performance status or patient has poor function, renal function, I will start with 30 milligram, and then I will adjust dose depend on the patient's tolerance. And we conduct a real-world study, as you can see in my presentation. The efficacy of treatments are the same in the two groups. I would like to talk more about the previous question about the concurrence of TKI and gamma knife and or whole brain radiation. I think the colleague asked this question because we have a data very long time ago that show the more toxicity in patients who treat concurrently TKI, Taxiva, I remember, with whole brain radiation. So in this practice nowadays, we have other TKI, especially osimertinib, in which the CNS response very good. So we can use osimertinib, and then we can replace the whole brain radiation therapy by gamma knife in nearly whole population of patients with metastatic brain metastasis. So I think if the patient need to have local treatment and with TKIs, if the patient cannot pay for osimertinib, I can use also gefitinib, erlotinib, or afatinib also.
So I guess everybody has their own experience. And there was a Japanese study starting with 30, and it doesn't seem to change the PFS, and even it was actually better than starting with 40, but it was not a good randomization. But this, we have to say this, that the recommended dose is still 40. So if you have, I most of the time start with 40, and if I have some problem, I reduce to 30. I hardly need to reduce to 20. So that's my experience of using.
I know, there is their official line, but why would I want the patient to suffer their grade 3 diarrhea before I lower the dose? I mean, in a way that it's no fun to have your grade 3 diarrhea
of course,
before you don't reduce. So why do we have to put them out of the experience because of certain companies say that this is my standard dose, and which was the wrong one?
Well, it was not really a wrong one because a lot of patients start with 40, no big problems. Well, and that's our experience.
Dose reduction in the study. I mean, 56% dose reduction, right? I mean, so yeah, there are 40% who don't, but then there are over 50% who do.
Well, it's the same for many other drugs. But I think this is something that you can be take your own responsibility in your practice. But we have some more interesting questions. We probably can put these two questions together because we have only a few minutes left. If I have a question on criteria of blood sample for ctDNA, which stage of disease should we have? Oh, please don't change. I cannot read changing lines. Okay, the other question disappeared. Should we use ctDNA to follow all patients?
Yeah, I think that is the question. I think that ctDNA still should remain as experimental for this time being. I don't think we have a proven effective intervention on when and how for the plasma DNA positivity. So you can give a sense of a prognosis, but we don't really have a good intervention. So at this moment, I think that we should be experimental, but I think we should do further study to define what is the exact step? I'm sure that you can tell us one of the study you guys are doing, right? You are doing some kind of study also in China using cfDNA as a treatment paradigm.
Yeah. So now we are take the ctDNA in the early stage, the local, the advanced disease, because with the prospective survey, if the MRD is the negative after the resection, and then the patient very rare the recurrence, and also this patient treated with the adjuvant, they don't get any benefit from the adjuvant treatment. So based on this data, now we initiate the phase 2 to phase 3 the clinical trial to compare if the MRD negative or the positive, how to treat the patient after R0 resection. So I think maybe in the 2 or 3 years we have to show the final result. Based on this result, and that time, I think we could say what is the real role of the ctDNA in the early and or in the local advanced disease. But for the advanced disease, I think now we only use this drug as the prognosis. We have any no data about the predicted data in the advanced disease.
Sure. For time limit, actually we have only 30 seconds now to lunch. Very quick. Do we do NGS and plasma to identify our tumor heterogeneity to select patients? Sure. Very fast.
Yeah, I think it adds cost to the situation, and so probably should only be experimental, because that again does not change our management for the time being. It just gives a bit of prognostic value for the time being.
Yeah,
so
it's a good research topic. So yeah, cfDNA, NGS outside of the practice is currently still research. So we have a very interesting discussion and very good talks by 4 speakers, Professor Kang, Professor Wu, Professor Mark, and Professor Nguyen. And I certainly hope that next time we can sit together and discuss rather than on the air. But for lunch, we have to close this session. Thank you very much for your participation.
Thank you.
Thank you. Bye-bye.
Thank you, everyone. We will now take a break for lunch, and we will resume at 1:05.